Peritonsilar abscess. Learning objective. Compare and contrast the upper respiratory tract infection according to cause, incidence, clinical manifestation management, and the significance of preventative health care. Introduction. Peritonsilar abscess, also called quinsy, is the most common major suppurative complication of sore throat, accounting for roughly 30% of soft tissue, head, and neck abscess. It most commonly affects adults between the age of 20 to 40 years, with the incidence roughly the same between men and women. This collection of purulin exudate between the tonsillar capsule in the surrounding tissue, including soft palate, may develop after acute tonsillar infection progress to a local cellulitis abscess. Severe bacteria are typically implicated in the pathogenesis of this abscess, including S. pyogenes, S. aureus, and Neisseria species, and Corynebacterium species. In more severe cases, the infection can spread over the palate into the neck and chest. Edema can cause airway obstruction, which can be life-threatening and is a medical emergency. Definition: peritonsillar abscess, collection of purulin exudate between the tonsillar capsule and the surrounding tissue, including soft palate, may develop after an acute tonsillar infection that progressed to a local cellulitis abscess. Peritonsillar abscess from near the tonsil. Pathophysiology. The exact pathophysiology of peritonsillar abscess formation remains unknown to date. The most accepted theory is that an infection developed in crypta magna that then spread beyond the confines of the tonsillar capsule, initially causing peritonsillar, then developing into peritonsillar abscess. Pathophysiology. Bacterial infection. Protective immunity not developed yet prone to infection. Stimulate inflammatory response. Tonsillitis, fever. Inflammation of tonsil. Sore throat. Tonsil increase in size. May obstruct airway. Clinical manifestation. The patient with a peritonsillar abscess is acutely ill with a severe sore throat, fever, thymus, inability to open the mouth, and drooling. Inflammation of the media pterygoid muscle that lies in lateral to the tonsil result is in spasm. Severe pain and difficulty in opening the mouth fully. The pain may be so intense that the patient has difficulty swallowing saliva. The patient's breath often smells rancid. Other symptoms include a raspy voice, odynophagia, a severe sensation of burning, squeezing, pain in while swallowing, dysphagia, sensation of burning, squeezing, pain while swallowing. Dysphagia, difficulty is swallowing, and otalgia, pain in the air. Odynophagia is caused by the inflammation of the superior constrict muscles of the pharynx that forms the lateral wall of the tonsil. This is causes pain in the lateral movement of the head. Assessment and diagnostic. Emergency department physicians frequently are the providers in who diagnose a patient with a peritonsillar abscess. A doctor may recommend an ultrasound to diagnose a peritonsillar abscess. Diagnosis: pharyngonoscopy, MRI, ultrasonic research, blood test, throat swab. Findings: cervical lymphadenitis, drooling, erythematous swollen soft palate with uvula deviation to contralateral side and enlarged tonsil. Muffled voice and hot potato voice, rancid or full smelling breath, pator, and trimose. Medical management. Antibiotics, either orally or intravenous, are required to treat a peritonsilar abscess. PTE medically, although most PTAs are refractory to antibiotic therapy alone. Penicillin is a congeners example. Amoxicillin, clavulanic acid, cephalosporin, and clindamycin are appropriate antibiotics. Nursing management. If the patient requires intubation, cricothyroidotomy, or tracheotomy to treat airway obstruction, the nurse assists with the procedure and provide airway obstruction. The nurse assists with the procedure and provides support to the patient before, during, and after the procedure. The nurse also assists with the needle aspiration when indicated. The nurse encourages the patient to use a prescribed topical anesthetic agent and assist with a throat irrigation or the frequent use of mouthwashes or gargles using a saline or alkaline solution at a temperature 40.6 Celsius to 43.3 Celsius and 105 Fahrenheit to 110 Fahrenheit. The nurse instructs the patient to guard a gently an interval of 1 to 2 hours for 24 to 36 hours. The nurse also observes the patient for a complication and instructs the patient about signs and symptoms of complication that require from anterior by the patient primary provider. At discharge, the nurse provides verbal and written instruction regarding smoking. The continuation of a good oral hygiene is also reinforced.